prevalence of plexiform neurofibromas in patients with NF1 is that roughly they arise in 30 to 50% of patients with this disease, and they're very variable in terms of their overall size, invasiveness, depth within tissues, and involvement with surrounding structures. The prognosis is also very variable because the phenotype in any one patient with NF1 can vary a lot, from people who are very mildly affected to those who have very severe disease with large tumors that are very invasive and difficult to remove. So it really depends on how severe and extensive their disease is and how many tumors they have and how severe those tumors are. Malignant peripheral nerve sheath tumors are actually a type of neurofibrosarcoma. It's a subtype of the sarcoma group of peripheral tumors, and these derive from Schwann cells, and they comprise 3 to 10% of all soft tissue sarcomas. They can develop anywhere in the body, but there is an increased risk by 20-fold of them occurring in the area where there's already an existing internal plexiform neurofibroma. The cumulative lifetime risk of developing a malignant peripheral nerve sheath tumor in an NF patient is roughly 8 to 13%, and it's very hard for us to predict who's going to get one and who isn't. So we kind of watch for red flags in a given patient in terms of a tumor that's growing very rapidly, has very rapidly escalating pain, a change in consistency of a given tumor going from very soft to very hard type of consistency, and then people that are developing rapidly rapid new neurological symptoms. In the perfect world, we like to approach neurofibromatosis one with a multidisciplinary team, and that will depend somewhat on whether you're an adult NF center versus a pediatric NF center. But in general, the team members we would like would be a neurosurgeon, a neuro-oncologist or a general neurologist, a adult medical oncologist or a pediatric oncologist, an orthopedic surgeon for any spine-related issues or other bony-related issues, an ophthalmologist to monitor the eyes and the vision, a physical therapist, occupational therapist, speech therapist, an audiologist to monitor hearing, and then a medical geneticist for advising on genetic issues. Most patients with NF1 will be followed by either an oncologist, a medical or pediatric, or a neurologist, could be a neuro-oncologist or a general neurologist, and they will do most of the routine follow-up and visits with the patient, and will do screening, CTs, and MRI scans to kind of follow them for any increasing tumor growth or issues that need to be dealt with. Then they often bring in the other specialists when needed, whether that's a neurosurgeon, an orthopedist, or an ophthalmologist, and they kind of help coordinate the care. So NF1 is a genetic disease. It's an autosomal dominant mutation in the NF1 gene located on chromosome 17. And this is a tumor suppressor gene, and roughly 50% of these people will have a family history of NF1. The other 50% will be developing through de novo or spontaneous mutations. And so it's very helpful to have a genetic counselor involved to talk to the patient and family about their risk for transmitting this disease to their offspring. The genetic counselor will go through the family history, see if they really do have a familial form of NF1, or maybe if it's more of a spontaneous mutation, and then give them advice on how likely it is to pass the disease on to their children.